It's quite a striking number when you hear it. Almost 2 out of every 10,000 babies born here in the UK have some kind of abdominal wall defect.
It really is. And it highlights why it's so important for us to, well, really understand these conditions.
Exactly. And today, we're going to do just that, a deep dive into one specific condition, Exomphalos. You might also hear it called Omphalocoele.
Mm-hmm. Think of this session really as high-yield revision. We've gone through the pediatric notes, pulled out the absolute essentials on Exomphalos.
Yeah, the aim is to give you a really clear, memorable picture of it, cutting through any extra noise.
So we'll cover the definition, what causes it, the risks, how it looks, diagnosis, and crucially, the management.
Right. We want this to be really efficient, leaving you feeling confident about the key facts.
Okay, so let's dive right in. What exactly is Exomphalos?
Okay, so at its core, Exomphalos is a congenital thing, meaning it's there from birth. It's a defect, an opening, in the baby's abdominal wall right at the umbilicus.
And through that opening, abdominal contents like loops of bowel, sometimes liver protrude outside the body.
But here's the absolute key point, the thing you really need to remember.
Yes.
In Exomphalos, those organs are covered. They're enclosed in a sac, a membrane.
Exactly. And that sac is made of the peritoneum lining the inside of the abdomen and the amnion from the pregnancy sac. That covering is vital.
It really distinguishes it, doesn't it? So maybe a quick mnemonic, Exo-Covered. Keep that in mind.
Good one. Okay, so why does this happen? What's the etiology?
Well, fundamentally, it boils down to a problem very early in pregnancy. The abdominal wall just doesn't complete its normal closure process.
Right. Those different parts of the wall are meant to fold and fuse, and in Exomphalos, that process gets disrupted.
And inside that covered sac, as you said, are abdominal organs.
Yes, absolutely. And it's important to know, Exomphalos often doesn't occur in isolation. It can be linked with other specific conditions.
Okay, that sounds crucial.
Yeah.
What are some of those important associations we need to be aware of?
Well, there's Cantrell's pentalogy. That's quite complex. Involves defects in the chest, diaphragm, abdominal wall, heart, a whole collection of things.
Okay.
Then there's Beckwith-Wiedemann syndrome.
Beckwith-Wiedemann. Right. How can we remember that one easily? It's a bit of a mouthful.
Yeah, maybe think of it this way. Big baby with belly button outie and big tongue.
Okay.
Because Beckwith-Wiedemann involves overgrowth. So after a larger baby Exomphalos, that's the belly button outie, and macroglossia, which is an enlarged tongue.
Got it. Big baby, OD, big tongue. That helps. Any others?
Definitely. We also see it more frequently with certain genetic conditions, specifically chromosomal abnormalities like trisomy 13, trisomy 18, and trisomy 21.
So Pitt-Edwards and Down syndromes.
Correct. And another one is cloacal exstrophy. That's a severe defect affecting the lower abdomen and pelvis, and it can sometimes include a low Exomphalos. And interestingly, even things like dental malocclusion or musculoskeletal issues seem to pop up a bit more often in kids who've had Exomphalos.
Wow, okay. So quite a spectrum of potential links. Just to lock that in, could you quickly name 3 key associated conditions again?
Sure. Beckwith-Wiedemann syndrome, trisomy 18, and Cantrell's pentalogy are definitely 3 worth remembering.
Perfect. Now, thinking about likelihood, are there particular factors that increase the risk of a baby developing Exomphalos?
Yes, there are several identified risk factors. We've mentioned genetic abnormalities already. They play a significant role.
Right.
Maternal diabetes is another known link. Also, the use of certain specific medications by the mother during pregnancy has been implicated. And having a family history of abdominal wall defects might slightly increase the risk too.
And didn't the notes we looked at mention some specific factors highlighted in UK studies?
They did, yes. Some UK-based research points towards associations with younger maternal age, certain substance use during pregnancy, and also maternal hypothyroidism.
Interesting, those UK-specific points. Okay, so we understand the what and the who. Let's just briefly touch on the how, again, the pathophysiology. Fundamentally, what's going wrong?
Well, as we said with the causes, the core issue is that disruption in the normal sequence of abdominal wall development during the embryonic stage. It's a complex choreography of tissue growth and fusion, and if that gets interrupted,
you end up with the defect.
Right.
Now, thinking clinically, if you see a newborn with a protrusion near the umbilicus, what else might be on your mind? What are the differential diagnoses?
Okay. The number one differential, the absolute must-know, is gastroschisis.
And the key difference?
No covering membrane in gastroschisis.
Yeah.
The bowel or other organs are just freely exposed. That's the crucial distinction.
Got it. Exomphalos are covered. Gastroschisis not covered. Super important. What else could potentially look similar?
Well, you might consider an umbilical hernia, but they're usually smaller, covered by skin, and often resolve spontaneously.
Okay.
Bladder extrophy is another possibility, where the bladder itself is exposed, but the appearance and location are usually quite different. And then, there are other much rarer types of congenital abdominal wall defects, but gastroschisis is the main one to differentiate from Exomphalos.
So thinking about other ways things can protrude in a newborn helps frame those differentials.
Yeah.
Good tip. What about how common this is, the epidemiology?
So in the UK, the figures suggest Exomphalos occurs in somewhere between 1 in 4,000 and 1 in 10,000 live births.
Right. And as we said at the start, overall abdominal wall defects are around that 1.85 to 1.96 per 10,000 mark.
Exactly. So it's significant enough that you definitely need to know about it.
Absolutely. So let's picture the baby. How does Exomphalos actually present clinically? What do you see?
The most obvious sign, of course, is that visible mass sticking out from the umbilical area. And crucially, it's covered by that translucent sac.
Right, the sac.
Inside the sac, you'll typically see loops of bowel, maybe part of the stomach, and sometimes even the liver, especially in larger defects.
And the size varies.
Oh, yes, considerably. The defect itself might range from maybe 4 centimeters up to 12 centimeters, or even larger in some cases. And its exact position can vary too. Sometimes it's central, sometimes a bit higher, sometimes lower.
And we touched on prenatal detection earlier.
Yes. Often the first clue comes during pregnancy. Elevated maternal serum alpha-fetoprotein MSAFP levels can be suggestive.
Okay.
Or, more commonly now, it's picked up on routine prenatal ultrasound scans. The ultrasound can show the defect and that all-important covering sac.
And you mentioned MSAFP levels can differ between this and gastroschisis.
That's right. Interestingly, MSAFP levels tend to be higher in gastroschisis compared to Exomphalos. It's thought to be because in gastroschisis, the bowel is directly exposed to the amniotic fluid.
Okay, that makes sense. Another potential clue during screening. And does the size of the Exomphalos itself have other consequences?
It can, yes. Particularly with large defects, the baby's abdominal cavity might be underdeveloped simply because the organs weren't inside pushing it out during development. Sometimes even the chest cavity can be smaller. And another really key point clinically, Exomphalos is much more likely to be associated with other congenital anomalies compared to gastroschisis.
So finding Exomphalos should really trigger a thorough search for other potential underlying issues.
Absolutely. It's often a marker for something else going on.
Okay, that's a crucial take-home. So how do we confirm the diagnosis? What investigations are typically done?
Well, as we said, prenatal ultrasound is really the cornerstone for diagnosis before birth. It shows the defect, the sac. If it's suspected prenatally, then genetic testing is usually offered. This often involves karyotyping to look for those chromosomal abnormalities we talked about, like the trisomies.
Right.
And the MSAFP level is part of that prenatal workup too.
Okay. And what about investigations after the baby is born?
After birth, ultrasound is used again to confirm things and get a good look at exactly which organs are in the sac.
Right.
Sometimes an MRI might be useful, particularly for seeing the liver's position relative to the defect.
And because of all those associations?
Exactly. Because of the links, further imaging is often needed. Things like a renal ultrasound to check the kidneys, an echocardiogram, and echo to look closely at the heart, and maybe even x-rays of the sacrum, the lower spine, especially if something like cloacal extrophy is suspected.
And why those specific ones? Kidneys, heart, spine?
Because those are common sites for associated anomalies seen with conditions like Beckwith-Wiedemann, the trisomies, or Cantrell's pentalogy. It's about actively looking for those known connections.
Makes sense. A targeted search based on known associations.
Precisely. And just to complete the picture, if prenatal MSAFE was high and the ultrasound was suggestive, amniocentesis might have been done during pregnancy to get fetal cells for that definitive chromosomal analysis.
Okay. A comprehensive diagnostic process. So once we have the diagnosis, what's the plan? How is Exomphalos managed?
Management absolutely requires a multidisciplinary team. That's key. Neonatologists, pediatric surgeons, geneticists, specialists, nurses, coordinating care both antenatally and postnatally.
Right. Teamwork is essential.
The definitive treatment is surgical repair, closing that hole in the abdominal wall. But when and how that surgery happens depends a lot on the size of the defect and the baby's overall condition.
Okay.
Good nutritional support is also critical right from the start, as feeding can be challenging initially. And, of course, ongoing monitoring and investigation for those associated anomalies is vital.
And it's not just a one-off fix, is it?
No, long-term follow-up is definitely needed.
And you mentioned the surgical approach depends on the size.
Yes. For
Mhm.
smaller defects, the surgeons might be able to do what's called a primary repair, basically putting the organs back in and closing the abdominal wall fairly soon after birth.
Okay.
But for larger defects, especially if the abdominal cavity is small, trying to force everything back in at once can be dangerous. It can raise pressure too much.
Right. That could cause problems with breathing or blood flow.
Exactly. So for larger or giant omphalocele, particularly if the liver is out, they might use different strategies. Sometimes an artificial patch is used to bridge the gap, allowing gradual closure. Or they might use a temporary covering, like a sterile plastic bag or silo. This holds the organs, allowing them to gradually reduce back into the abdomen over days or weeks as the cavity slowly stretches.
Ah, okay. A staged approach for the bigger, more complex ones.
Precisely. It's often called staged repair or gradual reduction.
And what about the very first steps, right after delivery, before any surgery?
Immediate care is focused on protecting that sac. Keep the baby warm, maintain intravenous fluids because they won't be feeding orally straight away, and cover the Exomphalos sac carefully with sterile, moist, non-adherent dressings.
To keep it clean and prevent drying out.
Exactly. Prevent heat loss, fluid loss, and infection.
Okay. So thinking about the bigger picture, what's the outlook for these babies? What does the prognosis look like?
Well, the prognosis is highly variable. It really depends on a few key things.
Right.
The size of the defect is one factor, but arguably more important is the presence or absence of associated anomalies, particularly major cardiac defects or chromosomal abnormalities, and the baby's overall health status, of course.
So things have improved over time.
Oh, definitely. Advances in surgical techniques, neonatal intensive care, particularly respiratory support and nutritional management like TPN, have significantly improved survival rates for isolated Exomphalos.
That's good to hear. Are there factors that generally point towards a more challenging outcome?
Yes. Things like significant intrauterine growth restriction before birth, having a large amount of the liver outside in the sac, liver out versus liver in, the presence of those chromosomal issues we keep mentioning, or having other severe congenital defects, these are all associated with a poorer prognosis.
So it really underscores that point about associated conditions being critical.
Absolutely. For a giant Exomphalos without chromosomal problems or major associated defects, survival rates with staged repair can actually be quite good now. But if significant chromosomal issues or severe defects are present, the mortality rate is unfortunately much higher. The associated problems often dictate the outcome more than the Exomphalos itself.
That's a really crucial distinction. Finally, what sort of complications might arise, either from the Exomphalos itself or its treatment?
There are several potential complications to be aware of. Infection is always a risk, either of the sac preoperatively or the surgical wound postoperatively. Bowel obstruction can occur later on due to adhesions from the surgery. Respiratory distress is quite common initially, especially with larger defects impacting lung development or raising abdominal pressure after repair.
Okay.
Then there are potential long-term issues related to any associated anomalies or sometimes from the surgery itself. Metabolic issues can arise, particularly with prolonged intravenous feeding, things like nitrogen imbalance, poor nutritional status, sometimes liver problems like cholestasis.
Right, the feeding challenges can have knock-on effects.
Yes, and severe malnutrition can increase the risk of sepsis or respiratory failure. For those with very large defects requiring multiple surgeries, there are risks associated with each procedure. And even later in life, there can be issues like potential liver injury or, in some cases, short bowel syndrome if significant bowel was compromised.
So it sounds like the initial defect can definitely lead to a cascade of potential challenges down the line.
It certainly can. It requires careful long-term management.
Okay, well, that's been a really thorough deep dive. Just to quickly recap the absolute key points on Exomphalos. It's that congenital abdominal wall defect where the organs protrude covered by a membrane.
Right. Remember, Exo-Covered.
Key associations include Beckwith-Wiedemann and the trisomies 13, 18, and 21.
Prenatal diagnosis via ultrasound is vital.
And management needs that multidisciplinary team with surgery tailored to the defect size, often staged for larger ones.
And the prognosis. Highly dependent on defect size, but crucially on any associated anomalies.
Excellent summary. Now, maybe something to think about after this. Given that strong link between Exomphalos and other sometimes serious genetic conditions, what sort of ethical considerations might come up around prenatal screening, counseling, and management decisions? Something to mull over.
That's a really important point to consider.
For anyone wanting to solidify this knowledge or revise other key topics for their exams, definitely check out PassTheMSRA.com.
You can also find a wealth of free revision material over at freemsra.com. Thanks for joining us for this look at Exomphalos.